Hello, everyone. This is Dr. Kaneez Fatima, a first-year resident at AIIMS Raipur in Department of Opthal. We have started a series wherein we will be discussing the video-based MCQs given the anxiety among the student uh, regarding the change in the pattern of the NEET. We have started this so that you are familiar with the new type of question if they do ask. So let's begin. This series would consist of 15 MCQs, which would intend to how to approach the questions and the new clinical vignette if they try to include in their new exam pattern. So let's begin. So starting with the first question, first we will go through the video and the options given, and then we will try to approach. The video shows a maneuver and the options, there are four options. First and foremost, the first instinct that one would get after seeing these four options, that these are the diseases from the ENT and the maneuver. We all have read about the maneuver, that is the Dix-Hallpike maneuver and the Epley's maneuver in one of these four diseases. But this should not be an approach. Rather, we will try to rule out each and every option and why that is not the option, and we will arrive at the correct answer. So basically, this is a maneuver wherein the head is turned towards the one side, and the question is asking like which procedure shown is most useful for treating. So we have vestibular neuritis, we have BPPV, we have Meniere's disease, we have labyrinthitis. So in vestibular neuritis, did we actually study any maneuver? No. Vestibular neuritis is the inflammatory condition wherein there is an inflammation of the vestibular nerve, and it is treated basically by the vestibular rehabilitation and not by any other maneuver. Next, we have BPPV. Yes, we do have read about the two maneuvers, that is the Dix-Hallpike maneuver and the Epley's maneuver. The Dix-Hallpike maneuver has a D for diagnostic and D for Dix-Hallpike maneuver. So it is a diagnostic maneuver for BPPV, and we have therapeutic maneuver, that is Epley's maneuver. So we will go in detail in that. Let's see the other option as well. We have Meniere's disease. The Meniere disease is basically an endolymphatic hydrops. That is, there is an excess production of the endolymph, or there is a impaired reabsorption of the endolymph, creating an excess of the endolymph, and that is treated by diet modification, that is treated by like diuretics and not by any maneuver. And we have labyrinthitis, the fourth option. The labyrinthitis, basically, it is an inflammatory condition of the labyrinth, and it is treated. It is like cannot be treated by some maneuver. So let's go into detail about BPPV. BPPV is, as the name says, it is benign positional paroxysmal vertigo. It is a benign condition wherein there is a paroxysm, that is an episodic vertigo that the patient experiences on the change of position. So why does it occur? It basically occurs wherein the otolith or the canalith from the macula in the utricle or the saccule, they get dislodged and go and settle down in the semicircular canal, the most commonly being the posterior semicircular canal. So the most common is the posterior semicircular canal, wherein the otolith they try to dislodge and go there. So the Epley's maneuver, it is a therapeutic maneuver wherein it consists of a series of steps of turning the head towards in different angles, and there we will try to reposition the canalith back into the macula of the utricle and the saccule. So it is used for the treatment of BPPV. So we can move to the next question. See the video carefully. So these clinical vignette, the video-based question basically they comprise of a two-step or a three-step question. The first, you will have to identify what is the procedure. Then you have to there would be a question related to that procedure, whether it can be a complication or it can be a treatment. So we will go through the video once again. Before that, we will read that the question says on the post-operative day 5, a patient developed sepsis. The CT abdomen demonstrates a peripancreatic fluid collection adjacent to the first anastomosis constructed during the reconstruction. So this video is basically a reconstruction and seeing the so many anastomosis, so many resection in anastomosis, one can come to a conclusion that it is a Whipple's procedure, a cancer which is a procedure which is used for the surgical management or resection of the head of the pancreas cancer or the periampullary cancer. So these consist of there are various steps in the resection as well as the anastomosis. So the question require you to identify the procedure, identify the reconstruction, and then you have to answer based upon that. So the question says like a patient develops sepsis and which of the following is the first anastomosis? Had the question not mentioned the first anastomosis, still and you can be able to arrive at the correct answer because the question gives another hint that is peripancreatic fluid collection. So we will come and we will see which anastomosis has most likely failed. So the question asks about the anastomosis will most likely fail. So we will go through the Whipple's procedure. So Whipple's procedure, it consists of various resection. So we draw a stomach with a duodenum, a jejunum. Then we have this pancreas, the tail of pancreas, the head and the body of pancreas. Then the liver is here. We have the two hepatic ducts. Then we have a common bile duct, which opens into a second part of a duodenum. And then we have a gallbladder. So basically, the Whipple's procedure, it consists of these resection. It consists of a cholecystectomy. It consists of a CBD resection. It consists of removing the head of the pancreas. It consists of a pylorectomy, wherein the pylorus here it is removed, and then a jejunum resection. So the remaining part are then anastomosed. So this anastomosis was shown in this video, which I shall be playing again. So we can see here it is a resection. The head of the pancreas is resected. The gallbladder is removed. Then the pylorus is resected and the jejunum is also resected. And then it is reconstructed. So the first anastomosis, which is done in the Whipple's procedure, it is a pancreatico-jejunostomy. The remaining part of the pancreas and the jejunum is anastomosed. So it is a first anastomosis. Next, the second anastomosis is it is done in disorder. We have pancreatico-jejunostomy. We have hepatico-jejunostomy. That is the common hepatic duct is anastomosed with the jejunum. And then we have a gastrojejunostomy. That is the stomach is anastomosed with the jejunum. So when we go through each of these, the first anastomosis, if the question has not mentioned the first anastomosis, you also get a clue that the first anastomosis is a pancreatico-jejunostomy. So when the pancreatico-jejunostomy, this anastomosis leak occurs, there would be a drain which would be rich in a turbid fluid. That is, would be very rich in amylase, and it would occur because of the post-operative pancreatic fistula. Post-operative pancreatic fistula, and this would present as the abdominal pain, sepsis, fever, which the question mentions here. Why it is not a hepatico-jejunostomy and not gastrojejunostomy? Hepatico-jejunostomy would present with a drain which will be rich in bile and not rich in amylase, and the symptoms would not be like in the form of sepsis or abdominal pain. Gastrojejunostomy, it is why the gastrojejunostomy is not an option, because the gastrojejunostomy would present as the feature of delayed gastric emptying and other stuffs, and not a drain which will be rich in amylase. And then jejunostomy would present as an anastomotic leak, and none of this kind, like peripancreatic fluid collection, wouldn't be explained by the leak of other three. So the answer, correct option is hepaticojejunostomy. Correct option is, sorry, the correct option is pancreaticojejunostomy, because the pancreatic leak would lead to a peripancreatic fluid collection. So we move to next question. Which nerve should always be assessed before and after this reduction procedure? So what is this reduction procedure? First, we have to identify. Then what it is used for, that we have to come to the clue, and then which nerve will be assessed. So it is a three-step question. So first we will go through the video once again. So after seeing the video, we come to a conclusion that it is a Kocher's maneuver, wherein there is traction. The first step, which is traction, then the arm is rotated externally, it is external rotation. Then it is moved towards the midline of the body, that is adduction, and then the arm is moved towards the side of the body, that is medial rotation. Team, as we have this mnemonic, team for Kocher's maneuver. And this is a close reduction maneuver for the anterior dislocation of the shoulder. For anterior dislocation of the shoulder. Now we have to we have to know that which nerve is most commonly injured in the anterior dislocation. So the most commonly injured in the anterior dislocation is axillary nerve. So we have to check this nerve before and after this reduction procedure, before, so that in shoulder dislocation whether this nerve is damaged or not, and after the procedure we have to see whether, because of this maneuver, the nerve is not impinged anymore. So this question will actually test you, like whether you know the anterior dislocation of the shoulder in detail or not. So this is a new trend of question which is increasingly being asked. So the explanation says the same. We have the video demonstrate the Kocher's maneuver, a close reduction technique for anterior shoulder dislocation. So before attempting the reduction, it is very essential to document the neurovascular status, particularly the axillary nerve, which is the most commonly injured nerve in the anterior dislocation of the shoulder. Now we move on to the next question. Despite the procedure shown in the video, the patient continues to have a persistent bleeding into a oropharynx. So what is the most appropriate next step in the management? We will go through the video and we will see what is the procedure being performed. We all have watched this procedure during our ENT postings in MBBS. So it is an anterior procedure of an anterior nasal packing. So the anterior nasal packing has been done, and the question says that the patient continues to have a bleeding despite this. So what would be the next step? We go through the options, each option one by one. We repeat the anterior nasal packing with an antibiotic ointment. Will this stop the bleeding? No. We will do a posterior nasal packing. We will come and see to this again. We will do an immediate septoplasty. No, immediate septoplasty just to stop the bleeding, it has no significance. Chemical cauterization with the silver nitrate, again, it doesn't have any significance. Will you repeat the anterior nasal packing with the antibiotic ointment? No. So posterior nasal packing, why will you do a posterior nasal packing? See, uh, the artery, the most common of the bleeding, nasal bleeding is from the Kisselbach's area, that is the Little's area in the anterior-inferior part of the nasal septum. So it is the most common area to bleed, and it consists of various arteries, and it is also one of the question which is being asked, like which artery participate in the which artery participates in the Kisselbach plexus. So we all have learned the answer, like posterior ethmoidal artery doesn't participate. So you should know the other four arteries also which actually do participate. So when the anterior nasal packing fails, the protocol is like when the anterior nasal packing fails and the patient continues to have a bleeding, we do a posterior nasal packing. Because the posterior nasal packing, it might be because of the bleeding from the branches of a sphenopalatine artery, the artery of the epistaxis. So even when the posterior nasal packing fails, then we go into some like invasive procedure. That is, we will do the endovascular embolization or the ligation of a sphenopalatine artery. So let's go through the explanation. The posterior nasal packing is the correct answer. We have arrived at the correct answer. The anterior nasal packing is the initial treatment for most of the cases of the anterior epistaxis, which commonly originates from the Kisselbach plexus, plexus also known as the Little's area. If the bleeding persists despite the adequate anterior packing, it suggests the source is posteriorly located, the most common being the branches of a sphenopalatine artery. So the posterior nasal packing is then performed to tamponade the posterior nasal cavity and then control the bleeding from the posterior vessel. So first you will do the anterior nasal packing. If the anterior nasal packing, the bleeding is still not controlled, then we will resort to the posterior nasal packing. And even when the posterior nasal packing doesn't control the bleeding, then we will go to the ligation of the sphenopalatine artery to control the bleeding. So we move on to the next question. So the question says a 56-year-old woman presents with a sudden thunderclap headache, vomiting, and a transient loss of consciousness. A non-contrast CT head demonstrates a diffuse subarachnoid hemorrhage. From the clinical clue itself, we can arrive at a provisional diagnosis, that is subarachnoid hemorrhage, the thunderclap headache, also the worst headache of the patient's life. Following the initial stabilization, the procedure shown in the video is performed. Again, this is a two-step question wherein they have given a clinical history. They have given a diagnosis as well. The question in main exam, the diagnosis might not be given and you have to guess the provisional diagnosis. And then the management, they're asking about the management. And then there are four options regarding the management. So this would mean there is a 2 to 3 step question. So we have to read each and every option in detail and we will watch the video now. They have entered the circle of Willis area and there is an aneurysm, large aneurysm sitting there, and some clipping is being done in this video. So what is the procedure being performed? Basically, it is a subarachnoid hemorrhage. We all know the treatment of surgical management of choice here would be an endovascular clipping. So regarding the endovascular clipping, we will go through the options, each option one by one. The primary objective of the procedure demonstrated is, so we have arrived, we have understood like it is a management of the subarachnoid hemorrhage, that is the endovascular clipping is being performed. So what is the objective of the procedure? What is the objective of the endovascular clipping? So first you have to like understand that the procedure performed, what is the procedure performed, and then the regarding the procedure, what is the significance of the procedure? This will prevent the delayed cerebral vasospasm by improving the cerebral perfusion. Okay, we will see to this again. This will obliterate the ruptured aneurysm from the cerebral circulation to prevent the rebleeding. It sounds more accurate. This will evacuate the subarachnoid blood to reduce the risk of communicating hydrocephalus. No, the surgical clipping will not evacuate the blood to reduce the risk of hydrocephalus. Whenever there is a large bleeding, that is an intraventricular hemorrhage, In that case, it leads to a hydrocephalus. And this is basically treated by EVD, that is external ventricular drain, which is a symptomatic, like it is symptomatically it is used to treat, like to drain out the excess blood. So this is an external ventricular drain and not the clipping. So this is not the option. The fourth is to reduce the intracranial pressure by decompressing the basal cistern. It is a decompressive craniotomy or cranectomy. So decompression is basically done when there is a resistant intracranial hypertension and it is not managed. So in that case, there is a need for decompression and not a surgical endovascular clipping. So this is again not the objective. The prevent the delayed cerebral vasospasm by improving a cerebral perfusion. Basically, we are obliterating the aneurysm and we are trying to prevent the initial rebleeding. So there is no role of the surgical clipping, endovascular clipping by like it won't improve the cerebral perfusion or in any way it would cause delayed cerebral vasospasm. So again, this is not the correct answer, and the correct answer is it will obliterate the ruptured aneurysm from the cerebral circulation to prevent the rebleeding. Basically, we are trying to stop the bleeding that is from the circle of Willis, anterior cerebral artery and the anterior communicating artery junction, the most common site of aneurysm. We will go through the explanation once. It will we have arrived at the correct answer. The patient has a aneurysmal subarachnoid hemorrhage suggested by the sudden worst headache of the life, thunderclap headache. And the procedure shown in the video, it is a microsurgical aneurysm clipping, which is performed to secure the ruptured aneurysm and prevent the early rebleeding, the leading preventable cause of death after the aneurysmal subarachnoid hemorrhage. Now we move on to the next question. The child shown in the video has a recurrent brief staring spells with the immediate recovery. Which of the following EEG finding is most likely? So basically, the video must have shown like the video must be showing some sort of spells or a seizure in the child, and then you have to identify the type of seizure and then you have to know like EEG findings of that seizure. So we will go through the video. The child is sitting completely blank. Suddenly the child has become blank. He is sitting in a classroom. He is very clueless, but there is no loss of consciousness, and the question mark indicates that the child is very clueless. But the child has not lost the consciousness. Normally, in cases of seizure, the child or a child or an adult, there is a loss of consciousness. But here, the child has like brief spells, that is very brief staring look. The child has given a very brief staring look, and the EEG finding. So we can get a clue from this, like it is a school going child and who has not lost his consciousness, and we can think as a provisional diagnosis of an absent seizure. The absent seizure basically present with such clinical presentation, and there is no loss of consciousness. The absent seizure is also known as petit mal seizure. Petit meaning small. So, and why it is known as absent seizure? Because it presents with a very minimal manifestation and not like a GTCS or a myoclonic seizure. So, we will come to the EEG findings of the absent seizure, but we will see like what the other option says. The temporal sharp waves, the 3 Hz generalized spike and wave discharge, hips arrhythmia, or the burst suppression. So these individual EEG finding, they are seen in different kind of seizures. So we will go through that one by one. The temporal sharp waves. The temporal sharp waves is basically seen in mesial temporal lobe epilepsy. Why it is not that epilepsy? In mesial temporal lobe epilepsy, the patient has some kind of post-ictal confusion, and there is also loss of consciousness in that. There are associated other features like hippocampal sclerosis, or there is also features of some aura in that. So in temporal lobe epilepsy, the temporal sharp waves of EEG is seen. So we cannot come to this. We cannot arrive at this answer based on this. Doesn't correlate with the video explanation. 3 Hz generalized spike and wave discharges. Yes, it is seen in absence seizure or a petit mal seizure. So before arriving at the correct answer, we will rule out the other two options as well. Hips arrhythmia. Hips arrhythmia is seen, it is a characteristic pattern of EEG, which is seen in infantile spasm. It is seen in West syndrome, also infantile spasm. In that case, the child would be having some salam spell, that is repeated flexion of the neck. But there is no such feature seen here. And burst suppression, the burst suppression is seen in some kind of encephalopathy or neonatal seizure. So doesn't correlate with the video, like the features shown in this video. So the answer would be generalized spike and wave discharge, which is seen in absence seizure or a petit mal seizure. We will go through this explanation. 3 Hz generalized spike and wave discharge. The child in the video is having an absence seizure, which is characterized by generalized 3 Hz spike and wave discharges on the EEG. These seizures result from the abnormal thalamocortical circuit activity and presence with a brief episodes of staring or a behavior arrest as the child look clueless while he is sitting in a classroom, and randomly, like for a very brief episode, the child is having a staring look. Sudden onset followed by abrupt recovery. There is no post-ictal confusion. As I mentioned, in temporal, mesial temporal lobe epilepsy, there is a post-ictal confusion also, and there is no immediate recovery in that, and the multiple episodes per day can occur. So the answer is absent seizure. So we move on to our next question. And the 40-year-old man underwent a surgery for a hip fracture 4 months ago. Based on the gait shown in the video, the injury to which of the following nerve is most likely? So the video must have been showing some kind of a gait, which we will identify after seeing the video. As a patient walks, there is a drooping of one side of the pelvis. The drooping of the right side of the pelvis when the person is on the stance phase of his walking on the left side. Stance is basically the weight bearing limb. When the weight is bare on the left side of the body, that is a stance phase, there is a drooping of the pelvis on the right side. So this gives us a clue that we are talking about a two kind of gait. We have Trendelenburg gait, and then we have a waddling gait. Trendelenburg gait, it occurs when there is a unilateral weakness. Suppose there is a weakness on the right side of the body, that is a right superior gluteal nerve, which supplies the hip abductors on the right side, that is the gluteus medius and the gluteus minimus, which actually supports and prevent the drooping of the pelvis on the opposite side. So it works in the other way. The right side, the right muscles, they actually lift the pelvis up from to of the left side. So likewise, the superior gluteal nerve, which supplies the gluteus medius and the gluteus minimus on the left side, they will cause the lifting of the pelvis on the right side. So whenever there is a palsy or an injury to the superior gluteal nerve on the right side, there would be a drooping of the contralateral pelvis. So here the patient has a drooping of the pelvis on the right side, meaning there would be a injury or a palsy of the nerve and the muscle on the left side. So the hip abductors, that is the gluteus medius and the gluteus minimus, is supplied by the superior gluteal nerve. And there is a damage to the nerve on the left side. That is why there is a contralateral drooping of the pelvis. So the question has asked like there is an injury to which of the following nerve? So the answer would be the inferior gluteal nerve. It won't, they are ruled out. So you can rule out the inferior gluteal nerve because they do not supply the hip abductors, gluteus medius and gluteus minimus. So you are left with two options, that is the right or the left superior gluteal nerve. Because the pelvis is drooping on the right side, the left side superior gluteal nerve must have been damaged. So the answer would be left superior gluteal nerve. Let's see the correct answer. The left superior gluteal nerve. The video shows the left Trendelenburg gait, indicating the weakness of the left gluteus medius and the gluteus minimus, the primary hip abductors. These muscles, they are supplied by the left superior gluteal nerve, as I explained now. The injury to this nerve causes the pelvis to drop on the opposite side during the stance phase. Stance means when the limb is into the floor, that is the weight bearing is happening. So there is a stance phase producing a Trendelenburg gait. So here we have this ortho anatomy integration wherein they ask like Trendelenburg sign is positive. So Trendelenburg sign is positive on the same side wherein the nerve and the muscle is damaged. Only the drooping of the limb pelvis occurs on the opposite side. Everything is on the same side. Like for the right side, there would be a right superior gluteal nerve palsy, the right hip abductors, that is the gluteus medius and the gluteus minimus would be paralyzed. The Trendelenburg sign would be positive on the right side, and there would be a contralateral, that is the left side drooping of the pelvis. So this covers another anatomy ortho integration question. Similarly, as I told, like when there is a bilateral weakness of the pelvis, it would lead to a waddling gait, and a unilateral weakness would lead to a Trendelenburg gait. So we will go to through the same type of question once again. Let us see the video and read the question. We have a 36-year-old is brought with a progressive difficulty in walking. Again, this is a question based on gait. Weakness of which of the following muscle group is most likely cause? So based on the explanation of the previous question itself, we can answer this. The man is walking and there is a like the gait is not unilateral, rather it is a bilateral, and the person has a drooping of his pelvis on both the side, leading to a gait which looks like how the penguin walks, that is a waddling gait. So waddling gait, it occurs when there is a bilateral weakness of the hip abductors, same, the gluteus medius and the gluteus minimus. So it occurs because of the weakness of the hip abductors and not the adductors or the hamstring or the quadriceps femoris. These are the like it is straight one liner. Only the thing is we have to identify the gait, and then you should know like that gait is because of the weakness in the gluteus medius and gluteus minimus, and the nerve supply is superior gluteal nerve, and they are the hip abductors and not adductors. The video shows a waddling gait, which is caused by bilateral weakness of the hip abductors, primarily the gluteus medius and the gluteus minimus. Okay. Next, a 58-year-old man develops the hoarseness of the voice following a right hemithyroidectomy. The laryngoscopic finding is shown in the video. Which nerve is most likely injured? So the nerve injured, the question is based on the endoscopic image, the laryngoscopic image of, and there is some kind of a nerve injury. Let's see the video. In this video, we can see that only the one half of the vocal cord is moving and the other half is paralyzed. It is a case of unilateral vocal cord paralysis. So which of the what is the cause of the unilateral vocal cord paralysis? They have given a history. The patient has undergone a right hemithyroidectomy. In right hemithyroidectomy, or a thyroid surgery, the most commonly injured nerve, it is a recurrent laryngeal nerve. So the right recurrent laryngeal nerve must have been injured, leading to a paralysis of the right side of the vocal cord. So which nerve is most likely injured? We know that it is a right recurrent laryngeal nerve, but why it is not the other nerves? The external branch of the superior laryngeal nerve. The superior laryngeal nerve का external branch supply the cricothyroid. And the crico, we know all the muscles of the larynx, they are supplied by the recurrent laryngeal nerve, except the cricothyroid, which is supplied by the external branch of the superior laryngeal nerve. And the cricothyroid, the function is TAD, that is tensor and adductor. Means it is responsible for the phonation, high pitch phonation. So when there is a injury of the external branch of superior laryngeal nerve, there would be a failure of the high pitch phonation and not the paralysis. So this won't be the answer. The internal branch of superior laryngeal nerve. The internal branch is basically a sensory nerve and doesn't have a motor action. So it supplies the inner part, that is sensation. It carries the sensation from below the vocal cord. It will carry the sensation. So again, it doesn't play any role in the vocal cord paralysis. The right recurrent laryngeal nerve. And then the fourth option is right hypoglossal nerve. The hypoglossal nerve, it is responsible for supplying the muscles of the tongue and has no role in supplying the vocal cords. So the correct answer would be the right recurrent laryngeal nerve, which is responsible for supplying all the muscles of the larynx except the cricothyroid. Let's see the explanation. The video shows a right unilateral vocal cord paralysis, most commonly caused by the injury to a right recurrent laryngeal nerve, which is a known complication of a thyroid surgery. And as the question has also given us the clue, there is a history of right hemithyroidectomy. The recurrent laryngeal nerve supplies all the intrinsic muscles. Yes, I forgot to mention the intrinsic muscle. It supplies all the intrinsic muscles of a larynx except the cricothyroid. So this injury will lead to a hoarseness and an immobile vocal cord and not um, it will lead to a immobile vocal cord. And the cricothyroid, the paralysis of the cricothyroid would lead to a failure of the high pitch phonation. Now, a patient undergoes a procedure shown in the video. Which of the following is the most reliable method to confirm the correct position of a tube before starting the feed? So the video might be demonstrating a procedure wherein there is an insertion of a tube. So let's see the video once. A tube is being inserted into the nostril of the patient with the head being extended. So it is uh, the most commonly you have seen during your internship posting. It is a insertion of a nasogastric tube. Had the tube being inserted into the mouth, it would have been an orogastric tube. So basically, the tube is inserted to obtain an access to a stomach, alternative access to a stomach. The question now says, which of the following is the most reliable method to confirm the correct position of a tube? Air insufflation with the epigastric auscultation, aspirating the gastric contents, the chest X-ray, patient's ability to speak. Out of the four options, the dummiest option, we all can rule out even without studying, would be the patient's ability to speak. Will the patient speak or not speak determine the position of the tube? Not, no, exactly. And the most reliable method, though. Chest X-ray, we will get back to this. Air insufflation with the epigastric auscultation. Yes, the most commonly done in the clinical. We don't do a chest X-ray after inserting a tube into a patient. Do we do that? No. Air insufflation with the epigastric auscultation. Yes, the most commonly used technique that we do to know the correct position is we do this. We put the diaphragm of the stent over the stomach, and then we push an air through the tube. That is a whoosh technique, we can say. We push an air and then we get a whoosh sound, and we know that the tube is in the stomach. But there is one disadvantage too. Like, they can happen that the tube is inside the trachea and the patient is unconscious, or the patient is intubated. In that case, the air from the respiratory tract would also produce the same whoosh sound, and you might be mistaken that the tube is in the stomach and the tube would actually be in the respiratory tract. So this is not the most reliable technique. The question has asked about the most reliable technique. The most commonly used is this only that we do in our clinical practice. But this is not the most reliable method. Aspirating the gastric contents? No. How the aspiration of the gastric content be the most reliable? Basically, we all know that during our instrument viva, we are very commonly asked about the radio opaque line in the NG tube. The radio opaque line in the NG tube is basically for this purpose only. We do a chest X-ray, and that line would actually guide that the tube is exactly tip of the tube or the tube is exactly in the stomach. So the correct answer would be chest X-ray. Now we will read the explanation. Chest X-ray. The video demonstrates a right tube or a nasogastric tube insertion, a procedure which is used to obtain the access to a stomach through the nose. Before using a tube, the correct placement must always be confirmed. But the gold standard is basically a chest X-ray or abdominal X-ray where the confirmation is required. And aspiration of the gastric content with the acidic pH will support the correct placement. But the most reliable is the chest X-ray. Simply auscultating the epigastrium while insufflating the air, that is a whoosh test, which I mentioned just now, is unreliable and should not be used as the sole method to confirm the placement because the tube may be inadvertently placed in the respiratory tract. And if the tube enters the trachea, the patient may develop coughing and choking. Yes, we can know that the tube has been introduced wrongly, but the patient can be unconscious or the intubated and these signs might be absent. So this is not the reliable technique. We move on to the next question. Despite proper occlusion of the deep inguinal ring, the swelling reappears when the patient coughs. So this clue basically gives like some process, some test or some process is being performed and the swelling reappears. The question points towards a case of hernia. Which of the following best explain this finding? So we will go through the video once. A finger is used to occlude some point and the patient is asked to cough and the swelling reappears on coughing. What exactly is this? So even though the question mentions here that there is an occlusion of a deep inguinal ring. Had the question not mentioned this, then also you can clearly identify from the video that above the midpoint of the inguinal ligament, the thumb is placed, meaning you have occluded the deep inguinal ring. And if it is just above the groin, it would have been the occlusion of a superficial inguinal ring, and the swelling will reappear when the patient will cough, means it is a reducible cough. It is a swelling with a cough impulse positive. Which of the following best explain this finding? Patent processor vaginalis. So first we will arrive like whether it is a direct inguinal hernia or an indirect inguinal hernia. In indirect inguinal hernia, the swelling or the hernia basically passes from the deep inguinal ring and then comes out from the superficial inguinal ring if it is complete or midway if it is incomplete. So it is an indirect inguinal hernia. And in direct inguinal hernia, there is a weakness in the posterior wall of the inguinal canal and the swelling or the hernia protrudes directly from the posterior wall. Okay, so here we have occluded the deep inguinal ring. So if even after the occlusion, the swelling reappears, means the hernia is not from the deep inguinal ring. It is not an indirect hernia, it is a direct hernia. Because in cases of indirect hernia, the occlusion of the deep inguinal ring would not allow the swelling to come out of the superficial inguinal ring. So it is a case of direct inguinal hernia. The swelling reappears when the patient coughs. Yes. So if they would have, so we will read each and every option. Patent processus vaginalis. Patent processus vaginalis is basically the pathophysiology behind the development of the indirect inguinal hernia. So it is not a case of indirect inguinal hernia because the swelling comes despite occlusion of the deep ring. So it is not. So it is not this patent processus vaginalis. Weakness of the posterior wall of the inguinal canal. Yes, it is the cause of the direct inguinal hernia. Obstruction of the superficial inguinal ring. If there would have been an obstruction of the superficial inguinal ring, the cuff impulse would not have been positive. So again, this is not the option. And the entrapment within the femoral canal. Entrapment within the femoral canal, there is no, it is a femoral hernia. So in femoral hernia, we don't perform the deep ring occlusion test. So the answer is weakness of the posterior wall of the inguinal canal. If the swelling reappears despite occluding the deep inguinal ring, it is likely a direct inguinal hernia. A direct hernia produced through the weak posterior wall of the inguinal canal. So even after blocking the deep ring, it would not prevent it from reappearing. So the entrapment within the femoral canal is not an option. The obstruction of a superficial inguinal ring, the cuff impulse would not appear, but the question said that the patient cuff, the swelling reappear. So again, this is not the option. The patent processus vaginalis. It is a case of indirect inguinal hernia, the pathophysiology behind the indirect inguinal hernia. So this is not the option. The correct answer is weakness of the posterior wall of the inguinal canal. So you have to rule out the three wrong options, and then the fourth one would be the answer and not directly arrive at the final answer. Next, the patient shown in the video is most likely to have which fundus finding? So basically, this video will demonstrate a fundus video or a fundus photograph, and the patient has which of the following. So you have to see the video and you have to arrive at the diagnosis. It is a one-step question. This is the optic disc, and the remaining area of the retina, the macula, the retina, and there is black spicules present in the fundus. So we have read about this fundus photo or this retina image. This is a very characteristic fundus photo of retinitis pigmentosa. Retinitis pigmentosa, there is bony spicules. There is a degeneration of the rods, and the patient develops rods are responsible for night vision, and the patient develops nyctalopia or a night blindness. And retinitis pigmentosa is basically, it consists of a triad wherein there is a attenuation of the arterioles, there is waxy pallor of a disc, and there is a bony spicule pigmentation in the fundus. So we can see one of those options, but we will rule out the three wrong options. Cherry red spot? No, the cherry red spot is just like a dot. It is just like a dot in the fundus. Cherry red spot. There are various causes: lysosomal storage disorder, Tay-Sachs disease, once among those different other cause. The cherry red spot basically it occurs because there is there is decreased blood supply in the remaining part of the retina, and so the particular part which receives a normal blood supply, it appears more reddish, and so it is not a cherry red spot. Salt and pepper retinopathy again doesn't look like a salt and pepper retinopathy. Bone spicule pigmentation, yes. The bone spicule pigmentation seen in retinitis pigmentosa. There is black degeneration of the rods. Drusen, drusen doesn't look like this. Drusen basically it looks like a yellow macular star kind of thing, which is seen in cases of ARMD, that is age-related macular degeneration. So it is not a drusen, and also the patient, in cases of drusen, the patient would be having the central vision would be lost. In retinitis pigmentosa, the peripheral vision is lost, and night blindness occurs and the peripheral vision is lost. So we will see the Explanation. Bone spicule pigmentation. The video demonstrates a characteristic fundus appearance of retinitis pigmentosa, and the patient typically present because this degeneration, early degeneration of the rods, so leading to a nyctalopia or a night blindness, followed by progressive peripheral visual field loss and leading to a tunnel vision. So classical fundus triad, as I mentioned now, there would be retinal arterioles attenuation, the waxy pallor of the optic disc, and the bone spicule pigmentation. So you can be asked like which of the following is not a triad of the retinitis pigmentosa. Whenever there is a three options or 3 points in favor of a diagnosis, the it becomes a potential MCQ question. We move on to our next question. The patient is undergoing the procedure shown in the video. Which of the following rhythms would not be an indication for this intervention? So what is the procedure being shown? We all have seen this scene in various movies. Okay, so this is basically a defibrillator which is performed, or in layman terms, we say that shock is being applied. But when it comes to medicine, there are different types. We have shockable rhythms and we have non-shockable rhythms. We will go through the option. We have this is a defibrillator. Okay, so defibrillation is basically done in cases of shockable rhythms. So among these, the shockable rhythms are ventricular fibrillation, we have pulseless VT, we have monomorphic VT with pulse and hypotension. Asystole is not a shockable rhythm. Asystole and pulseless electrical activity. These two, they are non-shockable rhythm and they are basically managed by CPR, by epinephrine, and not a defibrillator. So again, these three examples, they can be a potential question of a shockable rhythm. So the correct answer, the question has asked here, which of the following is not an indication. So whenever there's a question is not an indication, not true, or all except, so you have to be very careful. Like three would be the correct option and one would not be an indication. So here the indication which is not an indication in shockable rhythm, it is an asystole. So other option can be a pulseless electrical activity wherein we don't give a shock or we don't do a defibrillation. We see the explanation mentioned the same. Asystole and pulse electrical activity, they are non-shockable rhythm. They are managed with CPR and epinephrine and not a defibrillation. The video showed the defibrillation. Next, the examination findings shown would most likely be seen in all of the following except. So what is the video? Here, the pupil reaction is being tested by swinging flashlight test. The right eye, there is a constriction of the pupil, but in the left eye, in the swinging flashlight test, the normal response should be the constriction of the pupil. Rather, there is a dilation of the pupil on the left eye. So it is the case of relative afferent pupillary defect, RAPD, where we have different grades of RAPD, which we need not know now. But you should know that there is a rather the normal reaction would have been a constriction of the pupil. There is a dilation. So different grades, initial grade one, there is a mild constriction followed by dilation. So here the pupils have dilated. Means RAPD. The name itself says there is a defect in the afferent pathway. So which of the following this examination finding, that is the RAPD, is most likely to be seen in all of the following except. Again, you have to read the question in all of the following except, meaning in which of the following the RAPD is not present. Optic neuritis, yes, optic neuritis, the optic nerve is involved. It is an afferent pathway में involvement है. उसके बाद we have advanced unilateral glaucoma. Yes, it can occur. If we don't even know, we can move on to a next question. Next option, central retinal artery occlusion, complete oculomotor nerve palsy. Oculomotor nerve is not involved in the afferent pathway. Even though, like generally, opthal question they tend to ask, even you like you can know all the answers or you don't even know one. Still, despite not knowing the answer, you can choose one correct option. That is a complete oculomotor nerve palsy. The oculomotor nerve, it is a motor nerve which is involved in the efferent pathway and not the afferent. So you can come to a hint like the oculomotor nerve palsy would not lead to a like pathway in the afferent pathway. They won't affect the afferent pathway. Rather, they are involved in the efferent pathway. So it won't lead to RAPD. So meaning these three options can cause RAPD and not the oculomotor nerve palsy. So we have arrived at the answer. The complete oculomotor nerve palsy. The video demonstrate a relative afferent pupillary defect using a swinging flashlight test. So this is an afferent pathway defect and it is seen in conditions causing optic nerve disease. So it is most commonly seen in the optic neuritis and the advanced glaucoma, unilateral glaucoma. It is seen in CRAO and several others optic nerve or retinal pathologies. Now we come to the last question. The question seemed to be of some microscopic image, and the clinical vignette is of 65-year-old renal transplant recipient. He presents with the fever, altered sensorium, and neck stiffness. The clue gives the clinical feature of a meningitis. The microbiological examination in the CSF isolate is shown in the video. Which of the following most appropriate antibiotic microbial therapy? Again, the question have tested you in 2 to 3 steps. The patient present with meningitis, we have a microscopic examination of the organism causing that and what is the treatment of that organism. So let's identify the organism. This video characteristically shows us the tumbling motility of an organism, very famous bacteria, that is the Listeria monocytogenes. Listeria monocytogenes, it shows a tumbling motility, and it is also the most common organism which affect the extremes of ages, that is less than 1 year and more than 60 years. And that is also one of the reason why we add ampicillin. If you don't know the correct answer, like I used to remember like this, like ampicillin is given because the listeria is an organism which affect the extreme of ages, and that's why ampicillin is added. So you can also arrive at the answer, correct answer in that way also. Still, we will go through the options one by one. Ceftriaxone, the ceftriaxone is a basically a cephalosporin, and the listeria, they are intrinsically resistant to cephalosporin. So this in no way can be the answer. Ampicillin, yes. Vancomycin, though vancomycin is effective against the gram positive, but it is not the treatment of like choice for listeria or listeriosis, invasive listeriosis, because the listeria effect has actually progressed towards meningitis. So it is the invasive, just like invasive cryptococcosis, there is a meningitis. Like in that way, invasive meningitis, it would lead to meningitis in invasive listeriosis. Azithromycin, these they are not used in cases of invasive listeriosis. So the correct answer would be ampicillin. Let's see the explanation. The video demonstrates the characteristic tumbling motility of the Listeria monocytogenes in an immunocompromised patient presenting with a meningitis, that is stiffness and irritation. The Listeria monocytogenes is an important pathogen, and the ampicillin is a drug of choice for invasive listeriosis, and it is often combined with the gentamicin in severe infection. So we come to the end of this MCQ series and hope we will meet again in the next video. Thank you.